Today we are going to learn how to reduce a displaced fracture both bones forearm in a child. The two forearm bones in the human body are radius and ulna, which share a unique relationship with each other and are bound together by the annular ligament, interosseous membrane and the distal radio-ulnar ligament. This gives the forearm bones a unique relationship with each other, and that can be compared to a bundle of sticks and a linked parallelogram. Now the two bones can be divided into proximal third, middle third and distal third depending upon the location. We have the deforming muscles, biceps and supinator on the proximal third, pronator teres in the middle third and pronator quadratus in the distal third. Now because of the unique relationship between the two bones rendered by the proximal radioulnar joint, the distal radioulnar joint and the interosseous membrane, movements not only like flexion and extension which occur at the elbow joint is possible, but also movements like supination and pronation is possible. Now these movements are very important in carrying out activities of daily living. For example, full pronation is required to type on a keyboard, while as maximum supination is required to carry out acts of personal hygiene. So it is very important in a forearm fracture. One has to not only restore flexion and extension range of motion but also supination and pronation. The commonly seen fractures in the pediatric forearm are the torus or the buccal fracture, which is an incomplete fracture seen in the age group of 5 to 10 years, characterized by bulging of the cortex, which is most commonly seen in the distal radial metaphysis. Then we have the green stick fractures. The green stick fractures are characterized by a unicortical fracture with bending. As we can see in the X-ray, the opposite cortex remains intact. Then we have a complete fracture in which both the cortices are broken, and depending upon the displacement, they could be either undisplaced or displaced. Then we have the fracture dislocations, in which there is fracture of one bone along with dislocation of the other. In this X-ray, it's a Mortesia fracture dislocation. We had a 10-year-old child who came to the ER with a history of fall from height around 4 feet with fall and an outstretched hand. The patient presented with a lot of swelling, deformity and inability to move the limb. As you can see, there is an S-shaped deformity in his forearm and there is a lot of swelling and tenderness and crepitus. An X-ray was ordered, and here as we can see there is a displaced fracture both bones of the forearm in the distal third. Now I will demonstrate the reduction of the forearm bones. I have kept the forearm in pronation, and with the left hand I am holding 3 fingers of the patient, leaving the little finger, and with my right hand I am holding the thumb. I am giving traction, while as my assistant who is at the elbow is giving counter traction. This action of traction and counter traction will help me to disimpact the fracture site. Further disimpaction can be achieved by hyperdorsiflexing the distal fragment, that is, by exaggerating the deformity to around 90 degrees. Once the length has been re-established, the distal fragment is flexed in a volar direction into the line with the radius. By this maneuver, it is possible to gain complete apposition at the fracture site. Here the reduction was done without the aid of a C-arm or anesthesia, and the assessment of reduction is sometimes difficult, but often residual displacement can be detected by feeling the subcutaneous surface of the ulna in the region of the fracture. Now an above elbow POP slab is being applied, as the patient had a lot of swelling in the area of the fracture, and once the above elbow POP slab has been applied, one has to check for the distal neurovascular status. The post-reduction check X-ray of the same patient shows an acceptable reduction at the fracture site. At around 5th day, I'll remove the slab and look for the swelling. If it is subsided, I will convert the above elbow POP slab into an above elbow POP cast. Thank you.